advance refundable to purchase insurance. Now, the tax credits are going to vary by age, not necessarily by income. There is an income component, but the main variant here is age. And the idea is that we don't want to create income cliffs in terms of people saying, oh, if I make a certain, right now under the ACA, if you make a certain amount of money, you go over this level, you get cut out of premium support. And so we don't want to create this incentive in the government program to have someone say, I don't want to earn the extra dollar because I will lose my benefit. And as a person said, an employer recently said to me, he has people that come to him. He has a small landscaping business in Ulster County. People typically come to him, want a job, and they say, I want to work off the books because I don't want to lose benefits. And so what we're trying to do with the age-based tax credit is to avoid this issue where people have an income cliff. So the age-based tax credits start from $2,000, they go to $4,000 per person. $2,000 under 30, over 30, $3,000, and I think at one point it goes to $3,500, over 40, $4,000 a person. So that's the idea on the tax credits. The tax credits phase out over $75,000 of income for an individual and over $150,000 of income for a couple. The phase out, however, is you lose $100 of credit for every $1,000 you make over, say, $75,000. So if you're an individual and you have a $4,000 credit and you actually make $76,000, your credit is $3,900. If you make $77,000, your tax credit is $3,800. That's how that phase out works. So it's intended to address, to not give the credit to people that are higher earners, over $150,000 for joint earners. It starts to phase down. And of course, if you have dependent children, up to you can get up to $14,000 in that advance refundable tax credit for health care. Another thing that was done on the insurance side is we have created a $138 billion fund that is going to first start in 18 and 19 under federal auspices that creates a invisible risk sharing or invisible risk pool so that insurers can price premiums and deductibles for people without having the risk of having the high tail of expenses for certain people that have high medical expenses. John would know this better than me, but I think it's approximately 10% of the people use 70% of the dollars in the health.
550, 1070, 28.
Okay, 5% use 50%, 10% use 70% of healthcare. So I was close there. That was good. And so the idea is overriding idea in this establishing these high risk pools, reinsurance models, is to lower premiums and deductibles for everyone in the system by removing that tail liability risk for the insurer. And the invisible concept is modeled on the state of Maine, which ran a successful program on high-risk pools. So two people go to the insurer. One of them has a pre-existing condition, the other doesn't. The individual with the pre-existing condition who might have higher health expenses, that person doesn't know that they're at some point in their health experience, their costs are shifted to the high risk, the large pool that is funding it. So it's invisible to them. So to them, it's completely transparent. They don't see it, that the costs over a certain amount of money are being paid by the insurer. So the idea on the insurance side is to lower premiums and deductibles for everyone in the marketplace, because this is the overwhelming consensus of opinion that what is driving people crazy about the current system. Lastly, the legislation would permit a state, the ACA currently has age banding in it, 3-to-1. You can charge the 60-year-old 3 times what you can charge the 20-year-old. And The actuaries, the health underwriters, actually tell us that the pure number is about 4.8 to 1. So the legislation allows it to go up to 5 to 1 in terms of age banding. But this raises a question of what is the premium shock for the 50 to 64-year-old age bracket? And to respond to that, which the CBO actually raised a valid concern about, we added an $80 billion pool over 10 years to subsidize the premiums for the 50 to 64-year-old age bracket, the pre-Medicare age bracket. Pre-existing conditions are covered. You've heard some things that some people have suggested that they're not. It's absolutely not true. And we have the community rating up to 5 to 1 that I mentioned in terms of age banding. New York, by the one, has 1 to 1, and they literally destroyed their individual market for health insurance with 1 to 1 because it actuarially doesn't work. And we have guaranteed issue where the insurer is required to provide a policy. Now, you may have heard about this state waivers. I personally was very much against this, and I argued against this internally. I didn't win that fight, but I frankly feel that the Senate will absolutely strip this provision out of the bill. But here's how this would work. If a governor decides that he or she wants to pursue a policy where they waive certain essential benefits, not all the essential benefits, but certain essential benefits, he can seek a waiver from HHS. Now, who would the waiver cover? The waiver would cover approximately 7 to 10% of the entire insurance market in the individual and small group plans. It would not cover anyone outside of that who has large employer coverage. It wouldn't cover anyone on Medicaid or Medicare or TRICARE, which provides health insurance for the military. So we're talking about a universe of people that is 7 to 10% of the insureds in the whole country. Now, if a governor says, I want to try to get one of these waivers, that governor has to prove to HHS that the waiver would result in lower costs and higher coverage. And that may be a completely contradictory impulse, but that's what he would have to prove. If, for instance, someone had a pre-existing condition in a waiver state, which, by the way, wouldn't be New York, because New York already has these consumer protections in law, and no governor in New York State is going to be able to apply for a waiver. And frankly, I believe virtually no governor in the entire country would actually utilize this provision, which gets to why I was so vehemently against putting this provision in the bill, because it forces us to go through this tortuous explanation as to how that process would work. But were a governor to seek a waiver, and someone had a pre-existing condition, and they're in the individual thing, if it's only somewhat false. Well, they gave this allegation 4 Pinocchios 2 days ago. They wrote a column about this that said it's absolutely untrue. So people are unjustifiably and I think viciously being deceived as to what this provision means. I believe, frankly, at the end of the day, it doesn't really mean anything, and I think the Senate will take it out, which would be my opinion. So the real questions on the insurance side are these. Number one, are the advance refundable health tax credits, are they going to be enough for someone in that, especially that 20 to 30 age bracket, to get a plan? And are they going to be incentivized by the age banding to have lower costs to buy a plan? That's a question which I think still remains to be determined. The second question I have, and we've gone through this to quite a degree, I expect CBO is going to give us some analysis of this very soon, but is whether the high-risk reinsurance models, and you can bring the food in, don't wait for the food for me, these folks are hungry, whether the reinsurance high-risk pools that are being set up at the federal and state level with $138 billion of federal dollars, whether those numbers, whether that is enough. And the way I look at this, if it were not enough, we would appropriate more money to pay for them. And I think that's a critical component of this. But those are, in summary, the changes that are suggested on the insurance. Now, one other thing. those advanced refundable health tax credits, they can be used for any state-regulated health plan. They don't have to, like the ACA, only be used on an ACA-regulated plan. And this is a key component to opening up the market, to broadening the choices, to giving business and the small business community in particular more choices in terms of the variety of health insurance plans that can be offered. And I think the market would really open up in this regard. Medicaid. And this is from my perch on the Budget Committee. I can tell you that today our national debt is $19 trillion. In 10 years, the CBO told us back in January it's going to be $29 trillion. It's going to grow $10 trillion in 10 years. We are on the brink of a fiscal calamity, and with all of the stuff going on and all the arguments back and forth in our body politic today, virtually no one is talking about the financial calamity we are leaving for our children and grandchildren. And it really is a calamity. So, what is driving that? Overwhelmingly, what's driving it is demographics in the country. We are all living longer, in part because of all of what you do, but we have fewer people coming behind us to pay for the programs which many people in our country rely on: Social Security, Medicare, Medicaid, and the fourth real driver of this is interest on the national debt. If interest rates go up by 1% on the long term over the next 10 years, that's $1.4 trillion in addition on the national debt. Just a 1% increase over 10 years. So these are the kind of crazy numbers that we're looking at from the Budget Committee. So, Medicaid. What New York and the other states did who expanded Medicaid, they were told by the ACA they would get in perpetuity 90% reimbursement for the people that came in the expansion of Medicaid. And I think the number that you had up there was 1 million people just in New York State between the Medicaid expansion and the essential plan. So Medicaid, the promise of 90% reimbursement is not something that can be sustained. I can just tell you from a financial standpoint of the federal government, it cannot be sustained. So what is going to happen is eventually all the people that come into the expansion eventually are going to be reimbursed at the regular FMAP rate, which in New York State is 50%. In the meantime, however, some of us got provisions to cushion this transition. So the provisions are, up until the end of 2019, the state can still enroll people at the higher rate in the Medicaid expansion. A lot of my colleagues on my side of the aisle wanted nothing to do with that. But that was a condition of support. The other thing that we got is after 2020, anyone in the expansion today, anyone in the expansion will still get paid at the higher rate until they cycle off the program. And if someone cycles off the program, off Medicaid, then, and they come back, they get reimbursed, the state gets reimbursed at 50%, like it does for aged and disabled and children today. The other piece of the Medicaid puzzle deals with the essential plan. Now, this is a critical piece because of that 1 million, 600,000 are in the essential plan. The essential plan basically says we have a Medicaid-like coverage for people between 138 and 200% of poverty. It's Medicaid-like, but it's not Medicaid. It's very similar to Medicaid. How does New York pay for that? New York got a 1332 waiver, different from the waiver I was talking about before. These are kind of long-standing established waivers that CMS gives to state Medicaid systems. New York pays for the essential plan by a deal they made with HHS, which was a smart thing to do, where HHS compensates New York State for the people in their 138 to 200% of poverty from the premium support that would otherwise go to that person who was in one of the ACA exchanges. So if you're in an ACA exchange, bronze, silver, gold, platinum, if you're in an ACA, except for platinum, you may get an income-based premium support to help pay for your premium. If you are, what the state did for this cohort of people between 138 and 200 of poverty, it said we're going to give coverage to these people, and it was able to shift costs that the state was unilaterally paying for under a state court of appeals decision it was able to shift them into this essential plan, and it was a big fiscal relief to the state. So, the essential plan, the interesting thing about it, only 2 states in the country have the essential plan, New York and Minnesota. Guess what? There's no great consensus to say, oh, let's fund New York and Minnesota's essential plan population, because 48 states don't do it. But here's the key, and here's what my suggestion is to the state. Take the advanced refundable health tax credits that are available to people by age. Take those tax credits and convert them, just like you do with premium support today, into funding a pool of money for the essential plan. If they want to keep the essential plan, then go to HHS and CMS and say, we have 600,000 people or 500,000 people, however many it is, and we come up with a rate that each of them would be entitled to receive as an advanced refundable health tax credit, and we fund it in bulk to the state. HHS has said they will be promiscuous with waivers to the states. They will be very liberal and generous with the applications for waivers under 1332. So we could convert the premium tax credits for health, we could convert those into a method to replace the premium support that now funds the essential plan. Now, there obviously would have to be details worked out, but I think the rough estimates we're doing suggest that we would be able to fund all or most of what New York is now receiving under premium support for the essential plan. Medicaid generally there's one last provision which I personally wrote in this bill, and that is a provision which finally ends, and I campaigned on this in 2016. New York State is one of the only states in the country that requires the counties and New York City to pay for a significant portion of the state's Medicaid program. In fact, let me give you these 2 numbers, $9.5 billion and $7.2 billion. $9.5 billion is the entire amount that local governments spend for Medicaid in the entire United States of America. $7.2 billion of the 9.5 is in New York State. To give you a sense of how out of line and disproportionate New York is in terms of its forcing the locals to spend. So $5 billion of our 7.2 is New York City. So there's no way I could ask Albany in 2020, when this provision takes place, to cover both New York City and the county's program, because $7 billion would be too much. However, I can tell you this, from my experience doing state budgets and watching state budgets and looking at what they spend money on, they can definitely cover $2.2 billion if I give them 2.5 years to plan for it. So this would reverse this 50-year mistake that Nelson Rockefeller imposed on local property taxpayers. I exclude New York City because of the way I drafted it. I said, no, you can't foist this cost on a political subdivision in New York State, with the exception of a political subdivision that's more than 5 million people, which also has its own local income tax. New York City has its own local income tax. It's not complaining about its local Medicaid burden, and its budget is bigger than all but 7 or 8 states in the country. It is not really a county. It's more like a state. So that's the reason why I crafted it this way. Give you an example. In Albany County, about half of the county property tax that someone pays in Albany County goes for mandated Medicaid costs, which the county has no say over, none whatsoever. In Rensselaer County, 57% of Kathy Gimino's property tax levy goes to pay for mandated Medicaid costs that she has no say over. And so my argument is the level of government that sets the program, that decides the level of benefits, that determines the quality and size of its program, should be the same level of government that has to go to its citizens and say, we have to tax you to raise the money to pay for the program. It is called basic political science 101. As soon as we shift the burden onto the counties, what we do is we engender a system which for 50 years Albany has been able to foist some of its Medicaid burden, which in other states the states pay, foisted on property taxpayers. And what are the 2 things that people said the most to me in my year and a half going around this district that their kids and grandchildren have to leave because they can't find work, and their taxes are driving them out of their house. Those are the things that people have said the most to me. So this proposal, which I made when I campaigned, was intended to address that. I never knew at the moment that I would have a reconciliation bill that I could stick this thing in, but I did it after 3 months in Congress to reverse a 50-year bad policy in Albany. So that is the summary of this bill. Where I think it's going, I think the Senate is going to maintain two main things. It's going to maintain a system of tax credits. It's going to maintain insurance reforms that say most of the insurance regulation has to go to the state level. And it's going to maintain the invisible risk-sharing pool, maybe even at a higher level than the House did. It's going to maintain that so it lowers premiums and deductibles for everyone across the board. On Medicaid, it probably is going to be more judicious towards the states and some of the concerns of the governors that are concerned about the pace at which the Medicaid expansion would be terminated. So I think, from my vantage point, it is likely that the program, as it comes out of the Senate, will be better from our New York State parochial point of view. And I think that ultimately it would be much better if their negotiations can get 6 or 10 Democrats to buy into it. Because then we have a more bipartisan reform really of the ACA. And some of my conservative friends have said they are against this because this is really Obamacare light. This is the ACA light. In many respects it is, because some of the architecture is remaining, some of it is not, but the effort is to recognize the real clear need to expand coverage and lower costs. So that is the summary of this legislation. I really appreciate your attention. I'd be happy to try to respond to any questions that you might have.
So are you saying that the House bill has many flaws, which you acknowledge, but that you're counting? So are you saying that the House bill has many flaws, which you acknowledge, but you're counting on the Senate to fix the flaws?
No, that's not what I'm saying. I'm saying that there are provisions in the House bill that I would prefer to be somewhat different, and I expect that the areas where the Senate will make modifications will be in those very areas that I've expressed concern about. But I do think that the basic architecture of what was in the House bill will survive the Senate process.
Okay, also, the Medicaid cut, if you did that in concern for the balancing the budget or the budget deficit, why did that Medicaid cut turn into a tax cut for the very wealthiest of this country?
Well, so here's the concept on the Medicaid taxes. The ACA raised a lot of taxes. Elizabeth Warren even objects to the tax on medical device manufacturers. I firmly object I agree with her. I think that was damaging to us. I agree that we shouldn't tax insurers who just then pass the cost on to the people that pay premiums. I agree that we shouldn't have the tax on so-called Cadillac health insurance plans. The tax in particular that you're referring to is the 3.9% tax on capital gains. And I think the bottom line is that many of us believe that tax is a direct impediment to economic growth. So it is that tax is not going for budget reduction or deficit reduction. That tax is one that stymies economic growth. So that's the main concern about the capital gains tax. And history has shown that we actually, when we reduce capital gains taxes, we actually produce more revenue and we produce more economic growth. But I understand your concern. It's a valid argument about the bill from your perspective. Yes, sir.
It says that clearly that a lot of people will lose their insurance, but isn't it true that a lot of people that are insured now would opt out of the plan if they could?
Well, Here's one of the things, and here's one of the kind of mathematical symmetries that exist today. There are 20 million people that got coverage through the ACA, 12 or so million got it through the Medicaid expansion, and about 8 million received the coverage through the exchanges. At the same time, 6.5 million people are paying the fine rather than buying the insurance. Or like a young man I ran into in my town the other day, I asked him how he gets his insurance, because he has a local landscaping business, and he said, "Oh, I don't have coverage." I said, "Oh, you're paying the fine?" He says, "No, I don't pay it. I don't pay that either. I just deny it on my tax form." And I said, "Oh, okay." And I said, "Good thing I'm not from the IRS." But in seriousness, I think there are a lot of people like that, particularly younger people. 6.5 million people, mostly younger, are paying the fine. 12.6 million people or thereabouts have gotten explicit waivers from paying the fine for various reasons. So while 20 million people receive coverage, about 20 million people are also declining coverage or paying the fine or just lying about it, like this young man I ran into the other day. So that's one of those interesting symmetries. I do think that one of the keys to getting more young people in the pools, and this is why in some states the pools are collapsing, they don't have enough younger, healthier people in the pools to subsidize the cost for the older people that have higher costs. People like me, I'm 64. So, but 20-year-olds think they're invincible and they're never going to need this. So the key to me is to get those premiums down to, and with a tax credit, a health tax credit, to try to entice those younger people to buy coverage. And the question is going to be exactly what that's going to cover and how much it could be. So, I don't know if you have a thought on that, John, or not.
Well, I think, clearly the individual mandate has not produced the surge in people entering the market that the CBO said it did. And so that's why the coverage numbers have been so small on a relative basis. And so what the effect of the individual mandate is going to be when we take it away is kind of uncertain. If anything, we can be rest assured that the CBO will very likely overestimate. Just like it overestimated the positive effects, it will overestimate the number of people.
If that were really the issue, though, wouldn't the obvious answer to that be to increase the penalty and to make the IRS actually look at it more firmly? I mean, it sounds to me like you don't actually want to increase those younger people's coverage. I mean, you stated that the goals of the reform were to increase coverage and lower costs. I don't hear any specific efforts toward either of those goals. You're actually taking money out of the system by taking all those taxes away from the rich. Certainly you are. It's $300 billion people, $300 billion. And the other thing you're doing is you're getting rid of the...
I don't know, your guest, doctor, is from Dutchess County. I don't know if he's a physician or not, but...
He's a farmer.
He's a farmer, and
And one of your constituents.
and what difference does it
I
make?
don't think my question is irrelevant here.
Your question isn't irrelevant, but your statements
Can you
are-
explain to me how you're either increasing coverage or
You increase
reducing
coverage.
costs with any of these things?
You reduce costs by having the risk pools that would be established at the federal level to allow insurers to reduce premiums and deductibles by shielding the insurer
That
from the
doesn't-
very high-cost people.
That doesn't change the cost overall, though. The taxpayer is paying either through his insurance or through taxes in one way or another. You're not doing anything to affect
Just
the
like
healthcare
that-
system.
That's what the
that
Affordable
affects-
Care Act did.
Just like the ACA.
The Affordable Care Act did nothing to lower the fundamental cost of health.
Didn't it make a lot of effort to do
No,
that?
it did nothing. Zero. Zero.
I don't think that's what the CBO said.
The idea of the Affordable Care Act was not necessarily to lower costs.
That wasn't even the intent.
The intent of the Affordable Care Act was to provide more coverage for Americans.
Expand coverage, yeah.
Fair
That
enough.
was the idea.
No, then
My
that's why we're
question-
addressing this, which
I know,
which
but
he claimed the goals were to reduce cost and increase coverage both, neither of which seem to be addressed in any
Well,
way through everything that they're
because
doing.
you're not willing to listen.
No, I'm listening.
I explained to you that
I don't hear anything
Coverage-
addressing the cost of medical care in any of this, which is where the
Well,
cost is.
Well,
correct?
that question is one that would
Was
have to be
addressed
addressed,
under the ACA.
would have to be addressed in separate legislation from this.
Okay, so
final
you can take that off of your agenda, correct? That
No,
you're not trying to
not-
reduce costs.
not in
Unless
those-
you're saying you're trying to reduce taxes. You could say that for rich. You could say that. Or you could say you're trying to reduce premiums by making the coverage less. That's fair enough too. But let's be fair. We're not actually trying to reduce costs overall or trying to increase coverage.
We're trying to do both.
But I don't, explain to me how either one of those things works in this revision of the plan.
I vote for you.
Well,
Or not, I guess.
can we have more questions?
Go ahead.
Okay, I have a couple of concerns and questions. One, I listened to Mr. Paul Ryan on multiple occasions say that no bill should go through without a CBO score. And no bill should rush through. And this was one that went through without members. You can see him on TV talking about how they hadn't even had time to ring the bell. So we don't even know what some of these costs are because we don't have a CBO score. And he himself, Paul Ryan, the speaker, said he thought that was an important part. Many legislators to know what the CBO score is, whether we say over, or under. He said it was a necessary part.
So can I address that?
Yeah, I got a couple points, but you can address it. I just don't know.
So, the CBO score, for instance, when they passed the ACA in final form, was not available. This legislation is not the final word on this topic.
In a meeting with Tom Price 2 weeks ago, there's no intent that I see in CMS to alter their encouragement on Medicare towards value-based payment. The Secretary has made it clear, and we have gotten every indication from the CMS that nothing around innovation towards value-based payment is really going to change, that is going to continue. The standards for moving Medicare to value-based payment over the next, the 80% in 5 years, all remain. We see no change in that. In our discussions with CMS, both with Secretary Price and Seema Verma, we've seen no change in that at all. So,
I think that's great to hear,
and if you read this bill, it does not address any of that. Doesn't change anything because it doesn't address it.
One of the key components of value-based payment is to ensure that people, if you think about it, is to get people to primary care physicians, get primary and preventive care services provided.
Yep.
My concern is to ensure that any changes to the ACA and the essential benefits does not impact the ability of people to access their primary care physicians, such that they're looking at the deductible and saying, it's going to cost me too much to see my PCP.
Well, that's what's going on now. See, that's been the problem with the Affordable Care Act. The deductibles are too high.
Okay,
And
they're
that
gonna
has-
get higher though.
That has also bled into the small group market. So if you look at the small group market, the Congressman talked about, the 8 million people that now have coverage that they didn't have, and that is terrific, okay? But I don't know how many millions of people in the small group market who that has bled over to, and between the taxes and the change in benefit designs, are now faced with higher and higher deductibles. So the effect, and this has been a real effect on small business owners, and I talk to these people every day, and those are the people who are more likely to forego preventive care. They're actually the working people in small businesses because they don't get cost-sharing reductions that the very poor do. So what we've done is we really haven't solved the problem. We've just distributed it in a different way. And I think everyone agrees with that. And if you talk to Democrats on the Hill, they agree with that. I think one of the biggest problems with this is, and I'll conclude in a second, is that there's so much what I call frank nonsense out there. Okay, and it starts with Jimmy Kimmel talking about his kid, which is he's totally wrong. Babies don't have pre-existing conditions, okay, and they won't under this law either.
Right, but there are
So-
lifetime
no,
caps.
I'm talking now. And so the problem is.
Yeah, no, I'm talking right now. There are lifetime caps in the new AHCA.
And so the
Okay,
issue
let's-
is. And so the issue
let's
is
shut this down.
that with these sound bites, you can't get, and when you have a rational conversation with someone like the congressman who really knows a lot about this, and I spent a lot of time with the congressman, and he takes a lot of time to understand these issues. They're very complicated. And when you have the kind of fear mongering that we have, and this worry and all this nonsense, you can't have a rational debate. And as physicians, and I'm talking to the physicians now, as physicians, we have to be smarter than that.
Okay, good enough.
It's the
Okay,
balance.
Thank you.
Well, thank the Congressman for.
Great to be here. I appreciate, even though I didn't get to eat dinner, but you know, with my weight, I should lose a few pounds, so I appreciate it. Thank you.